So thanks for that kind introduction, Matt, and thanks for everyone who's attended today. And I'm truly grateful for the opportunity to speak today. It's not often we're provided with such a platform to provide a summary of our PhD. Before we begin today's talk, I would just like to take the opportunity to state that I have no conflicts of interest. And as Matt said, the title of today's talk is A Call for Cardiac Screening in a Pediatric Athlete. And by pediatric, and for the purposes of today's talk, in line with many definitions of NHS service lines, I mean an individual aged 18 or less. So the learning objectives of today are somewhat questions identified before I embarked upon my PhD. And these are, do pediatric athletes actually have an athlete's heart? And you might even question, are they athletes? Can current recommendations for ECG interpretation in athletes be applied to the pediatric athlete? And what are the upper limits of cardiac physiological remodeling in a pediatric athlete, i.e. how big do their hearts get? So before we devolve into these questions, I think it's important we ask why. So why should we even undertake cardiac screening in a pediatric athlete? And I'm going to adopt what is, in my opinion, a pragmatic approach to this, driven by a position statement from the American Medical Society for Sports Medicine. And in this position statement, it's a rationale statement. I'm going to briefly consider three main categories identified within this statement, and they are athlete risk, the benefit to harm of cardiac screening, and resources. So for the purpose of today's talk, I mean resources in terms of our current understanding of the pediatric athlete's heart. So what is athlete's risk here? The athlete risk is incidence of sudden cardiac death or arrest in a pediatric athlete. I believe I can comfortably say that all of us in this room have seen such traumatic events on TV or online or even indeed in person. And we understand that this is a truly catastrophic event, devastating for families of victims, peers, clubs, and the sporting community as a whole. But we want to know how often does this occur, and are pediatric athletes at sufficient risk to warrant cardiac screening? So let's take a moment to look at the available evidence. When considering the risk of sudden cardiac death in young athletes, as per a joint position statement from the American Heart Association and American College of Cardiology, it was written the following: sudden deaths attributable to cardiovascular disease in young athletes in the United States occur at an annual rate similar to lightning strike fatalities. So I'm going to take a step back and appraise this statement a little bit, like similarly inspired by Dr. John Dresner. And thankfully for me, the National Oceanic Atmospheric Administration have kindly done me the favour of doing all the legwork here. So if we look at lightning strike fatalities between 2008 to 2018, the average amount over this period was 27.4. And if we look at our denominator, our population at risk, we have an average population in the US of 316 million. So that gives us an incidence or risk of 1 in over 11 million. And if we compare that to a recent outcome data from cardiac screening in an adolescent soccer player in England with a mean follow-up period of 10 years, the risk in an adolescent soccer player is 1 in 15,000, constituting a almost 780-fold increased risk. If we consider only the black adolescent soccer player, that's less than 1 in 4,000, constituting a 3,110 increased risk compared to a lightning strike fatality. So I think we can comfortably say that pediatric athletes are sufficiently greater risk, substantially greater risk than a lightning strike fatality. But what about benefit to harm in terms of false positives and detection rates? As per the views of a health economist, cardiac screening has a low potential to reduce deaths because of its poor detection rate and uncertain effectiveness of the management of the diseases. Secondly, it induces harm because of its high number of false positive test results, leading to temporary or lifelong disqualification from competitive sports, psychological and financial harm, and follow-up and treatment with unknown benefit. Accordingly, it was recommended that as long as those at high risk of sudden death cannot be reliably identified and appropriately managed, young athletes should not be submitted to pre-participation screening, in his views. I, of course, disagree with this statement, and I'm going to explain why I disagree by looking at the available evidence of cardiac screening in the pediatric athlete with the view of answering those questions I identified in today's learning outcomes. So what about our resources, our current understanding of the pediatric athlete heart? So before we ask, do these athletes have, pediatric athletes have an athlete's heart, we might ask, indeed, are these children even athletes? Some of you in the room might know whom this is. She was born in 1997. In 2011, at just 14, she won the World Junior Elite Championship. In 2012, she was training 32 hours per week. This, of course, is Simone Biles, a truly special, remarkable athlete who at the age of 22 today has won a remarkable 24 Olympic and World Championship medals. But of course, this is just one-off incidents, so does it extend across the board, that systematic training at a young age? Well, if we think about the professionalisation of academies in England, right from foundation, under 9s to under 21s, where coaches and practitioners are instructed to chase 8,500 hours of deliberate practice. And in real world, how this works out, at Manchester United, for instance, while children as young as 8 are undergoing systematic training as much as 4 hours per week, I think we can consider children to be athletes. And if we consider the Arab pediatric athlete, in light of the recent Youth Summer Olympic Games, where there were 17 countries of predominant Arab ethnicity competing, winning a collective 34 medals, I think we can too consider the pediatric Arab athlete to be indeed an athlete. So do pediatric athletes present a heart then, if they are an athlete then? A question we sought to answer within a systematic review with meta-analysis. And I don't expect you to recall all of these. This is just an indication that yes, they do, and we do see an athlete's ECG on a pediatric athlete when presented with them in a clinic. But what is abnormal then? If we know they do present an athlete's heart, what constitutes abnormal in the pediatric athlete? Well, here is a 13-year-old Arab footballer who presents anterior T-wave inversion across her precaudal leads V1 to V4. And in our systematic review, we find this to be prevalent as many as 6.5% of athletes and 5.7% of non-athletes. But I think you could agree with me that 1 in 15 don't have a heart condition that could increase the risk of sudden cardiac death or arrest here. So how can we accurately distinguish between what's normal and what might be an indicator of pathology here? So first question you might ask is, what ethnicity is this pediatric athlete? And if we first consider the white pediatric athlete versus the black pediatric athlete, we can see a clear shift here. Indeed, a almost threefold increase chance of presentation of anterior T-wave inversion in black athletes compared to white athletes. But what about age? If we consider a cutoff of 14 years and compare less than 14 versus older than 14, if that's correct, yep, we can see there's a relatively small shift here, which is actually quite surprising because we usually associate anterior T-wave inversion as a juvenile pattern. And I'm going to get back to this at a later point in the talk as to why I think this might be the case. So this brings us our question. Can current recommendations for ECG interpretation be applied to the pediatric athlete? And indeed, what are they? So the first main body of guidelines here for the athlete in terms of ECG interpretation was the ASC 2010 recommendations. And over the years, we've sought to improve these in view of reducing our false positives, i.e. triggering further diagnostic tests with no heart conditions being detected in the form of Seattle and international recommendations. And I think it's important to recognise in these international recommendations, Aspetar has had a key representation here in the form of Matthew Wilson, Nathan Ryden, and Dr. Carmen. And what are they then? Okay, so like their predecessor, they have a number of normal findings, which would not trigger further evaluation. And again, a number of abnormal findings, which would not trigger further evaluation, But importantly, in terms of differentiation to its predecessors, was the identification of a number of borderline findings for the first time. And if these were present in isolation, they're now considered not to warrant further evaluation. But if 2 or more are present, further evaluation is warranted. But perhaps of most significant for the purposes of today's talk was for the first time the recognition of the juvenile T-wave inversion pattern. And that was considered normal in athlete aged less than 16 when confined from V1 to V3. So what is that T-wave inversion V1 to V3 that I'm talking about here? And here's a brief example. You can see it confined V1 to V3 and regard it to be normal in that individual less than 16. So what if we apply these new international recommendations in athletes to the paediatric athlete aged less than 18? How effective might they be? So we indeed did this. Although we're a small state in the Gulf region, we've screened athletes from all over the world. Indeed, paediatric athletes from over 48 countries, over 800 Arab, over 400 black paediatric athletes. So if we apply them then, what do they look like? If we consider both age and ethnicity? Well, of course, these are athletes, so relatively unsurprisingly, there was a high percentage of normal ECG findings being presented. And in agreement with the international recommendations, there was a number of borderline findings presented in isolation. Further agreement, few, 2 or more, and again, relatively few abnormal ECG findings. But how many of these athletes would have been cleared to play off an ECG alone, without requiring any further diagnostic tests as per international recommendations? Well, a significant amount. Indeed, as many as 97% of Arab paediatric athletes aged 13 to 16. But on the flip side, we've got relatively few triggering for further evaluation, but it's important that I recognise that black paediatric athletes aged 11 to 14, there was a high proportion here. So we're not triggering many for further evaluation. And so how many of in that case, how many of these that we have triggered for evaluation have we actually detected a heart condition, and have we potentially missed any if we apply these international recommendations? So I'm briefly going to consider a Roc curve here, and what we have on our x-axis is the specificity, that's the probability of testing negative in the absence of a heart condition. On our y-axis, we've got the probability of testing positive in the presence of a heart condition. And what we get here is if we have a line like this, it's essentially a 50-50 chance of being correct. So it says abnormal, 50-50 chance of being a heart condition, but 50-50 chance of no heart condition. Whereas also on the flip side, normal, there's a 50-50 chance of there being a heart condition here. And what we all strive and want to achieve is a test like this. And essentially, but this is, as we can appreciate, difficult in medicine. And in this test, we would have, every time it says normal, no heart condition. Every time it says abnormal, heart condition present. But what I want you to distinguish once we're looking at these different criteria for ECG interpretation and indeed the health questionnaire and physical examination is that the more space underneath the curve, the better the test is. So if we compare them, we can see that our international recommendations are superior here, giving us a fair diagnostic accuracy. But that's all well and good. I want to know what this actually means. So you might indeed ask, what can I take to the clinic tomorrow? So I'm going to use some odds ratios and likelihood ratios from an infogram published by Aspetar's very own Rod Whiteley. And I'm going to use an explanation here delivered by Nickel before me because it was very elegant and very good, and there's no better way to explain it. So let's forget for a moment everything we know about sports medicine and sports cardiology. And let's consider the chances of a pediatric athlete presented in front of us of having a heart condition that might kill them the same as a coin toss. So if we flip a coin, there's a 50% chance of this coin landing on heads or tails. So a 1 in 2 chance. So odds of 1 to 1. And let's say I've got this test, and this test has a positive likelihood of 2. That same individual's chance shifts from 50% to 66%, sorry. So 2 in 3 chance or odds of 2 to 1. And if we apply this to the pediatric athlete, and let's say we're presented with 100 pediatric athletes for first-time cardiac evaluation, we find that the chance of detecting a heart condition without undergoing any tests was 1%. So in other words, 1 in 100. With odds of 1 to 99, sorry. And let's say this ECG was abnormal. We've got a positive likelihood of 8.9. So that same individual's chance in the same individual, the chance of detecting a heart condition shifts from 1% to 8.3%. So 9 in 108 or 9 to 99. And I appreciate that's still 8.3%, but in terms of the potential sinister outcomes of such a heart condition, I think you can appreciate this is a big shift. Now, if I was to flip that, and let's say that test was normal, we get a negative likelihood of 0.4. So that same individual's chance shifts from 1% to now 0.4%. So 0.4 in 100, 0.4 to 99. So to answer that question, can current recommendations be applied to the pediatric athlete? My answer is yes, but with two buts. One is that we need to apply this to different populations to truly know that this is indeed valid and it will work in other populations, not just our population. But the second but is international recommendations provide us a fair diagnostic accuracy. And I don't know about you, but I want to know if we can do a little bit better. So my next question was, can we take this a step further? And we, for a brief moment, consider only our Aspire student athletes, both here in Qatar and our Aspire Dream program, specifically over 400 Arab and over 300 black pediatric athletes. And if we cast our mind to this anterior T-wave inversion pattern, in the instance where it's present in two contiguous leads, so two of these four leads, and let's say we're presented with 100 pediatric athletes again, there's a 16% chance of observation of this pattern in a pediatric athlete. And this is indeed concerning because anterior T-wave inversion is associated with hypertrophic cardiomyopathy, arrhythmic right ventricular cardiomyopathy, and indeed, in some instances, myocarditis. All diseases we know have an increased chance of or risk of sudden cardiac death or arrest. But some of these athletes present other ECG findings that would warrant further evaluation anyway, so let's remove them for a brief moment. So now we're down to 13%. So 1300, or odds of 13 to 87, still have this anterior T-wave inversion pattern. So how do we distinguish what's normal here to abnormal? Because 1 in 7 here don't have a heart condition that could increase their chance of sudden cardiac death or arrest. So if we think about that anterior T-wave inversion in terms of how to interpret it as per international recommendations, if it's confined to V1 to V3, and that individual age, with a chronological age less than 16, that individual is cleared to play. But let's take a little step back and think of some previous research that was conducted in Italy, where they looked at predictors of that T-wave inversion pattern in a pediatric athlete. So they looked at male sex, they looked at chronological age less than 14, and they looked at incomplete pubertal development. And we all know these kind of graphs, but just to make it clear that if we have anything with a confidence interval that falls on 1 or over 1, it's non-significant. So what did predict anterior T-wave inversion in these white pediatric athletes in Italy? Well, male sex didn't, chronological age less than 14 didn't, but incomplete pubertal development did. But incomplete pubertal development here was assessed by Tanner staging. Tanner staging is considered by many to be invasive, and there is child protection concerns here. So what else could we maybe use to try and determine maturation or indeed biological age here? What about skeletal age, regarded to be the single best maturational index by the International Olympic Committee? And I know what you're thinking here, I don't want to expose these kids unnecessarily to radiation. But don't worry, the radiation from this is negligible, corresponding to just 1 hour of background radiation for major cities in the UK. So let's consider athlete A and athlete B here. We've got a chronological age of 9 years, but athlete A has a biological age of 6 years, and athlete B has a biological age of 12 years. So that's a 6-year swing within a 9-year-old. So what we're clearly observing here is that while chronological age is this linear factor, biological is anything but, because it's a biological variation. So when we applied it to our apparently healthy pediatric athletes with no heart condition detected, what might predict this anterior T-wave inversion here? So if you look at chronological age less than 16, driven by our international recommendations, the same in terms of biological age here, and black race, which we know from the adult population, and that systematic review with meta-analysis I showed you is another predictor as such of anterior T-wave inversion. And again, there's that one with the confidence interval. So what predicted it then? Chronological age didn't, but biological age and black race did. So let's think about 100 pediatric athletes that present that anterior T-wave inversion confined from V1 to V4 with no other ECG abnormalities, so in 2 contiguous leads here. The chance of detecting a heart condition in this population was 1%, so in other words 1 in 100 or 1 to 99. And let's interpret that ECG as per international recommendations governed by the passport. We get a positive likelihood of 0. So in that same individual, the chance of detecting a heart condition changes from 1% to 0%. So 0 in 100 or 0 to 100. And if we were to flip that, and let's say that player is cleared to play without any further evaluation, we have a negative likelihood of 1.1, so that same individual's chance goes from 1% to 1.1%, so chance of 1 in 100, or odds of 1.1 to 98.9. But how about if we interpreted that ECG by biological age, so that's that skeletal age I showed you. We get a positive likelihood of 15.8, so that our chance of detecting a heart condition changes from 1% to 14%, so 1400 with odds of 16 to 99. And if I was to flip that and say those that were cleared to play as per governance by our biological age, we get a negative likelihood of 0, so our chance of detecting a heart condition flips from 1% to 0%, so 0 in 100, 0 to 100. So what next? Based upon this ECG abnormality, or indeed as a diagnostic test imposed irrespective of the findings presented on a physical exam, medical questionnaire or ECG, owing to the cardiac screening program imposed, what might we do? Well, to increase the sensitivity to detect heart conditions, a resting echocardiogram is sometimes undertaken. And the intention and goal of implementing this diagnostic tool is to accurately differentiate between what might be a marker of physiological remodeling, i.e. an athlete's heart, or an indicator of cardiac pathology. So brings us to our last outcome of today, which was what are the physiological upper limits of cardiac remodeling in a pediatric athlete? But wait a minute, these are just pediatric athletes with limited training years, low testosterone levels, so we can just apply reference values from the general pediatric population, can't we? Well, if we think about that systematic view with meta-analysis, when we imposed a meta-regression, even after accounting for age, pediatric athletes presented larger left ventricle structural parameters than non-athletes. And if I briefly for a moment cast your mind to what is the often forgotten right side of the heart, specifically if we think about the right ventricle and the diagnosis of arrhythmic right ventricle cardiomyopathy, a disease with a 16-fold increased chance of death during physical activity in a competitive sport athlete. I think you can agree with me that in a cardiac screening program, it is prudent to detect such diseases. And if we think about this criteria, which is predominantly based on adults, indeed only 8.3% were based on 12 to 18-year-olds. So we expect adults, of course, to have bigger hearts, don't we? And based on this current criteria, focusing on cardiac size alone, how many of our pediatric athletes would meet criteria for possible arrhythmic right ventricular cardiomyopathy? Well, if we think about this measure of heart, the measure of heart size from the parasternal long axis, 70% would meet minor, and indeed 22.7% would meet major, so 1 in 4. And almost 1 in 2 would meet minor from the short axis views, and 1 in 10 would meet major. But I think you can agree with me that 1 in 4 or 1 in 10 pediatric athletes who present for first-time cardiac evaluation do not have possible arrhythmic right ventricular cardiomyopathy. So what we're seeing here is what we've seen in the adult population for a number of years, and that is an overlap between what constitutes athlete's heart and what might be an indicator of a subtle cardiomyopathy. And indeed, the picture gets a little bit more complex. If we think about a recent review, the complex phenotype of the athlete's heart, there's a number of factors that we should perhaps consider here. And they are body size, sex, ethnicity, sporting discipline, biological maturation, and indeed age. But for the purpose of today, I'm going to think just about body size. We're often told we have this heart that is the size of our fist. Indeed, we understand our heart is responsible for pumping oxygenated blood to our working muscles and key organs. And we understand that we all go through maturational years, increasing in chronological age, and we too grow in stature and weight. So if we think about this heart as the size of our fist, we might logically think that there's a nice linear association between increase in body size and our heart size. And indeed, that's what we've often thought for a number of years. But in reality, we know this is a physiological phenomenon, and anything that's physiological is non-linear, i.e. it curves off at some point, doesn't it? And if we consider this worked up example, this pediatric athlete who presents to us at age 11, and if we track this individual up to the age of 16, what we see is a variable growth pattern. You'll see from age 13 to 14, we've got a big jump in body size, and again 14, 15, and up 15 to 16. But we're increasing cardiac size at the same time. And I don't know about you, but trying to distinguish what might be a normal physiological response here to training, or what might be a disproportionate growth and perhaps an indicator of a heart condition to an increase in body size. Because we've got a non-constant variance here. So this is a really complex phenomenon. So what might we be able to do to make this process a little bit simpler? A common approach in pediatric echocardiography includes the use of Z-scores. So the Z-score is how much above or below this measure is to the population mean. So Z-score essentially equals our observed measure minus our predicted measure based on body surface area, chronological age, what it might be, and our predicted standard deviation. And for that measure of cardiac size I've just presented to you, we've got a nice elegant question here, an equation that's pretty easy to recall and quite easy to compute based on this individual's body surface area. I'm sure you can agree. And if we think about the minimum data set defined by the British Society of Echocardiography, with all these views and measures, I'm sure you could just recall all these equations easily, especially once we consider that in some instances we only have, 20 minutes to undertake an echo, get nice pristine images, take these accurate measurements, sometimes take their height and weight. That's easy, isn't it? Or what I could do is provide you with a nice nonogram here. And this allows us, you can see our predicted mean in the blue in the middle, our 1 Z score above and below, and 2 Z scores above and below in the red. And this is really quite useful because we can visually track that allometric growth and see, okay, he's increasing body surface area, but is that proportionate to what we would expect in terms of cardiac size for that increase in growth? And that's quite nice as a visual tool. But if I want to get a nice accurate Z-score, I'm going to still have to compute these complicated equations you've just given me. And I've got all these measures to do that on. So how could we maybe make this a little bit easier? I bet in your hand right now, or indeed in your pocket, you've got a device. A device, in the UK at least, you go online with 24 hours a week with. So 1 day a week, you're online with this device. What if I was to put this on a website that would allow you could use on that handset, or indeed a laptop or a desktop? Well, that's what we've did. It's not online yet, and it will be once we publish this data. But all you have to do is put in the patient's height, weight. Don't worry about body surface area, we'll calculate that for you, and then put in their age. And if you just put in their observed measure, you'll get an automated calculated Z-score. So no need to recall these complex equations, both for the left heart and the right heart. And I think you'll agree with me if we think about that worked up example where I gave you, where we had all these measures, we had an increase in height, weight, with this chronological age. If we pay attention to the Z-scores, that process becomes a little bit easier to distinguish between what might be a physiological response or perhaps an indicator of a heart condition. So in summary, our questions for today was, do pediatric present an athlete's heart? I think we can say yes. With next question was, can current recommendations for ECG interpretation be applied in a pediatric athlete? I think, again, we can say yes in a male pediatric Arab and black athlete, but we probably should repeat this in other populations. And of course, we don't know if this is applicable to the white pediatric athlete or indeed the female athlete yet. But there does appear to be refinement possible with governance by biological, not chronological age when presented with anterior T-wave inversion confined from V1 to V3. And what about those upper limits of cardiac physiological remodeling in a pediatric athlete? How big do they get and how variable is that upper limit in a pediatric athlete from 11 to 18? Well, indeed, they are variable. And during pediatric years, we can support the tracking of allometric growth by the application of Z-scores. I could stop here, but we could briefly look to the future. We know echocardiography has been undergoing significant advancements in the development of its technology over the past years. And with this, there's been an increase in rise in the use of and development of speckle tracking echo. And it's widely understood that a number of these cardiomyopathies that we're trying to detect have an age penetrance. Indeed, in the athlete, they're quite often not band-on cases, they're subtle cases of these heart conditions. So it's therefore possible that with the use of speckle tracking echo, together with our standard functional echocardiographic parameters, that we might have an increased sensitivity and thus allow early detection of these heart conditions. And indeed, if we think about a recent position statement from the British Society of Echocardiography and a cardiac risk in the young, and I don't want you to, for all intents and purposes, I don't expect you to recall these different measurements, but if there is a case of suspected heart condition, what they do recommend is an exercise stimulus. And we don't know what these predicted measures are, what we might expect to see truly in a pediatric athlete yet. So we need some data, normative data, to allow us to help distinguish what might be normal and what might be a subtle indicator of a heart condition here. And if I was to bring you back to where I started today in terms of that outcomes from cardiac screening in an adolescent soccer player, and this paper in its own right really is a journal club discussion, so I'm just going to pay attention to a few points here. They detect a vast majority of, a number of heart conditions which saved the lives of a number of athletes. And I want to allude to what's often forgotten in cardiac screening programs is that 73.8% of these athletes were allowed to return to play. So there is some positive outcomes with detecting heart conditions. Of those 26.2% which were advised not to play, it's important to recognise that in two instances, there was cases of hypertrophic cardiomyopathy, and they did return to play against medical advice, and they did unfortunately proceed to die. And I think anybody like me who would be a screening advocate, it would be remiss or misguided for me not to consider another fact. Of those over 10,000 that were cleared to play, it's important to recognise there were 6 that did proceed to die who had no detected heart condition. So I think it's important to and that did constitute 8 cases of sudden cardiac death, giving us an incidence rate of 1 in less than 15,000. And bear in mind, this is actually one of the highest incidence rates that we have seen in athletes. Truly underscores the problem here. So bearing in mind that 6 cases that we didn't detect a heart condition from that one-off assessment at a chronological age of 16, I think it's important to recognise that incidents like this are a reality, and screening is not perfect and probably never will be, despite how much we may strive to improve our ability to detect heart conditions. So for any sporting organisation, I think it's imperative that they're equipped with AEDs and proper training in order to react quickly when such an incident occurs. So just to wrap today's talk up, I just want to give acknowledgements to everyone who supported me along the way, most notably my supervisors in the form of Professor Matthew Wilson, Dr. David Oxburgh and Professor Keith George, and of course our team who've allowed us to obtain all this data and impose a lot of our cardiac screening. Without these individuals, we couldn't do research full stop. So it's important to recognise individuals, and I'm truly grateful for everything you've done for us over the years. Thank you.